challenges for, oh, thanks, Erica, for the program and for each of you all, not maybe everyone, but for a lot of you as scholars and for our teams. Um, the program experienced a transition kind of suddenly and in the middle of the program where Tina, and you all remember Tina from our first session, Tina Not Dog, who was the leader of the this program and really had been leading this for the last several years, transitioned into a new role and out of the medical society. And that was a sudden transition for this program. And and we had to respond as leaders of the program to that. And you have seen a new team form, and we are joined today by Manisha Thomas. Really excited to have Manisha here. Manisha, turn it over to you in just a second, just to kind of introduce yourself. But excited to have Manisha join the team. Erica, has been the backbone of this program now for several years, and this year we've been delighted. I know Asia Luray, I see the claps. Huge kudos to Erica, which has really kept us floating and running and riding and gliding forward this year. And this year has been the first year we've had two program directors or managers and program leads in Laura Ocollier. And I saw Laura before, although I think she's having some audio and connection difficulties, and Scott Paviol. And so our team has been in a process of transition. That's been challenging for the scholars on. And yet you all have been strong as teams and resolved as people and resilient as leaders kind of getting to tonight. And so we are delighted to kick off. I'm delighted to kick off. I think we're all delighted to kick off this graduation. Couple of hours. I don't think we'll take all the time, but we had as much time as we need to hear about your growth as teams. We're going to do so by hearing about the leadership projects that you've been working on, but hidden in those leadership projects is personal and team growth that has occurred throughout the session.
This meeting is being recorded.
There we go. It is important. And this is really an opportunity to come together as scholars, as also as a broader community. So you'll see some names you may not recognize, who are leaders in the medical society and leaders around the state who are joining in to listen and to ask questions and discuss, some of the things that our scholars are going to present about work they've been doing. So the flow of tonight is each leadership group, will have an opportunity to present some slides and present a discussion of what they've been tackling. We expect the groups to dive into problems. They may propose some solutions. We would be a little flighty if we thought that groups over the course of 1 year were going to solve a social determinant of health problem. But to spark discussion is really the key goal of tonight. Each presentation will be about 10 minutes or so, and then there's an opportunity for discussion. And I would encourage all of the great faces that are on and not on to really use this opportunity to engage in discussion with one another. It may feel a little bit strange to ask your fellow scholar questions, but that really is the goal. And some of those questions may be about the social determinant of health problem that you hear, because each of these presentations are about social determinants of health. But some of them may be about the challenges, the successes, the difficulties, and the celebrations that you all as teams encountered as you went through this, and what you may have learned during that. So this is a great evening, and we're excited to be with you. Manisha, do you want to just reintroduce yourself, and then maybe we'll go around our leadership team and kind of kick it off to the first group?
Thank you so much, Dr. Stroud. Good afternoon, everyone. My name is Manisha Thomas. I've been with the Medical Society now for about 2 months, and I am really happy to be here with the Future Clinician Leadership College members. I look forward to hearing more from you during your presentations about how you really rose to this leadership challenge. I would like to reach out to a couple of you, because one of the things that I'm going to be doing, working with Erica, Dr. Stroud, Dr. Paviol, and Dr. Ocollier, is to make some tweaks to the program so that we can make sure that your colleagues that come after you get a wonderful, beneficial program that is an advantage to them as they move forward in their careers. So please be on the lookout for an email from me, but I'm also going to place my email in the chat box. And so if you would like to reach out to me, please feel free. We just want to make a couple tweaks to the wonderful program that's been set up just for future cohorts. And so I'll turn it back over to Dr. Stroud.
Thanks, Manisha. We're going to thank Erica profusely at the end, but she's working off some loud noises behind her. So we're great to have, excited to have Erica here. Scott, anything you wanted to start us off with before we go to our first group?
Trying to get my camera on, but my truck is making it illegal, which is probably good. No, I mean, y'all are the best and the brightest, and you have everything ahead of you. You know, Roy and I were in your seats at one point, and you know, always bet on yourself and keep your compass at true north, and you'll get where you need to go, and you're already taking the right steps. So you're already on path, and you know, just keep pushing and keep doing what you're doing. Sometimes that's the best advice. Just keep doing what you're doing. I'm proud of y'all.
Thank you, Scott. You keep driving and keep doing what you're doing and listen in and
Okay.
be safe. All
Yes, sir.
right. Well, we are excited about tonight's agenda, and let's kick it off with the first group.
And if you just give me some type of audio cue to advance your slides or a head nod, that's fine. I'll just advance them when you're ready.
Thanks, Eric. I think we can go to the next one. All right, we got our first group, Healthcare Interpretation Services for North Carolina, and we're excited to hear from this group. We'll turn it over to you all.
Alrighty, hi everyone. Thanks so much for joining in today. So my group, which consists of me, Nolan, Raina, Charles, and Julie, we decided to do a project on the healthcare interpretation services for refugees in North Carolina. So essentially what we looked into was just how access to interpretation services, especially for refugees, like differs based on the different healthcare systems and also the different geographies throughout North Carolina. And before I pass on the baton to Nolan, just want to give a shout out to Julie. She's really kept us super organized and kept us on task for this project and really, really carried the team for us. Alrighty, Nolan, whenever you're ready.
Alrighty, so I think one of the things we've all learned this year is that in a healthcare setting, really effective communication is crucial. So our research aim for this project was to investigate how access to interpretation services, particularly for refugees, really varies across North Carolina. So in 2023, 2.4 million people were in need of third country resettlement, and really accessible interpreter services are essential for refugees. So it really promotes effective communication, integration, but particularly within healthcare systems. And without it, I think we all know that refugees and really any patient that needs an interpreter service is at a much higher risk of a misdiagnosis, improper treatment, and health deterioration. Alrighty, so North Carolina is really home to a significant number of refugees from really diverse linguistic backgrounds. So between October of 2023 and May of 2024, almost 2,400 individuals were resettled as refugees in North Carolina alone. And this ranks North Carolina 8th in the country for total number of refugees resettled. And then 1 in 12 North Carolina residents are immigrants. And then in Mecklenburg County, the state's second most populous county, that number rises to nearly 1 in 6 people are immigrants or from an immigrant background.
And so with this diverse group of refugees that we're seeing, it's really difficult to say that we have the infrastructure necessary to provide services for these people. One big thing that's really holding the state back is the lack of state level investment and standardization. And what that means is that there is a huge variety of things that can be offered. So for example, if you go to Greensboro that has a really diverse and robust refugee population, you'll find very different resources than you will in Chapel Hill, despite the fact that you might see more refugees in Greensboro. So it really depends on the provider and geography. Those major health systems like UNC, like Duke, offer 24/7 interpreter services. However, a lot of the times, and especially for more niche languages, which are often the refugees that come in speaking languages that we don't necessarily have interpreters on hand for. The availability is there, but the access and the ability to actually use it is not always there. There are organizations like the North Carolina Community Health Center that bridge the regional divide and that really try to connect people to interpreters within systems. We also don't necessarily have a statewide certification program. And so that means that we have interpreters coming through that don't necessarily have the same certifications as their neighbor, just one county over would. And that means that if someone has to go to a specialist, if someone's in a rural county and has to come to in-state, is someone coming in from a rural county going into a more urban county, they'll see a different array of services that they're able to access because of that. There's also a lot of context around the reimbursement policies that we have. So they actually discourage the use of language service agencies because they don't reimburse them directly. So major health systems like UNC and like Duke might be able to directly reimburse, but it is not a statewide policy. Next slide. And so here are some solutions that we're seeing. There are a lot of different ways that you can tackle this issue. One big thing that we're seeing in Massachusetts, so I went to undergrad in Massachusetts and worked in a lot of clinical settings there, and they have a huge, basically an infrastructure setup that is intended for people who are displaced automatically. So there's Boston Medical Center that sees a lot of refugees. There's an established refugee clinic at the Family Health Center of Worcester. And there's a lot of training programs that are available through the Massachusetts Department of Public Health. We have the MOIA, the Mayor's Office for Immigrant Advancement, that's currently in place, does a lot of work specifically with the refugee population. And it's all intended towards making a state that's more welcoming towards displaced people. There's a lot of training around sensitivity as well, and the overall result that we've seen is an increased patient satisfaction among low English proficiency populations. There's also places like California that have specific mandates meant for health plans there, which means that they reimburse and they do provide necessity for language access services to LEP, to people with low English proficiency. That means that they're professionally trained interpreters who all have the same training and translated materials available. And if not immediately available, they'll often be available through an external resource, so like through a social worker. What they've seen is a 20% reduction in emergency room visits because of an increase in primary care visits among lower English proficiency patients.
We're also seeing emerging advancements that happen, especially in technology, using natural language processing models to be able to bridge this gap. And California is an example of a state that is trying to do this. Their Health and Human Services Agency is currently seeking bids from tech firms for this initiative, but they're starting with just document translation. They haven't yet defined exactly what these documents will look like. They broadly say that it'll be related to health and social service information, programs, benefits, and services. I know just like in my clinical training, if we have like a Arabic speaking patient and I've tried to get like an interpreter to at least translate their discharge paperwork, but that often takes a lot of time and it may not be readily available. And I remember having to wait like half a day for that to happen. And so I know that this would make that process at least a lot more accessible and a lot more easier to make sure that they're getting the necessary information, especially as we try to bridge the like inpatient to outpatient transition as well. So the eventual goal of these technological advancements will be to transition to real-time translation. However, this comes with concerns of their own. There are experts that believe that the technology may not be able to handle the nuance that's necessary to handle sensitive information, to have the technical accuracy that's needed, and to respect the cultural subtleties that are present in healthcare conversations. And the other thing is that errors in this setting have detrimental consequences. So we need to be extra careful about how we're using the technology. And this also means that we need intense regulatory oversight. I believe that this is unfortunately going to be an instance where the technology is going to advance faster than the regulation keeps up with it. So we may at first see a lot of issues that then will prompt regulation to come forth. The other thing that we also saw was addressing financial barriers. This is just to reinforce the idea that there needs to be financial incentives to be able to have a better system for interpreter access. So in Switzerland, they did a case study where healthcare providers were made aware of the available funding for interpreters, and just knowing this made them significantly more likely to utilize these services and led to better health outcomes. So if we're able to at least advertise like, hey, like we have a government insurance program that's going to reimburse you, that then at least gets rid of that barrier in a provider's mind and enables them to better utilize these resources. Next slide, please. And we also wanted to highlight some of the programs that are currently existing in North Carolina that is doing this work. And we believe that these programs should be further supported and expanded. A great example is Cone Health Family Medicine Residency Program in Guilford County, where there's about 800 plus refugees resettled each year. And they have a specific refugee and immigrant health clinic that provides primary care to this population. They're also part of this Refugee Health Coalition, which is made up of 8 different community health partners that try to create resources to help the refugee population. And this includes nursing programs, local refugee resettlement agencies, as well as the Cone Health Center for Children, Inclusion, and Family Medicine. They even did a refugee health literacy toolkit that was a welcome to health that's written in English with Swahili translation. And it contains information on how to navigate both living in the US and how to navigate its complex health system, which is not as intuitive as we would like it to be, even for native English speakers. In a similar vein, Duke students in 2017, as part of a class, created informational videos to help new arrivals adjust in North Carolina, where they simulate confusing scenarios such as how do you shop in a supersized grocery store, how do you ride public transit, etc. Things that we may not think of first when it comes to healthcare, but obviously will lead to better health outcomes when you can access fresh food and can get to your appointments on time. And so these were available in English and French, but have plans to expand. And although these efforts are making strides in smaller segments of the state, we are advocating for comprehensive reform to be able to expand these services to the rest of the state. Next slide, please.
Pardon me, let me get mine. So in summary, North Carolina has a rapidly growing refugee and immigration population, and a multitude of diversity in socioeconomics and linguistics and different cultures. And so obviously there's a need. There's a need for these people to be able to get, equitable and adequate care, which is seen in the way of just being able to understand the providers that are providing that care for them. Although, our state has made strides in major health systems and communities, to offer these interpreter services or these like services, for example, what we talked about with what Julie talked about with, navigating America or navigating North Carolina. There's still significant disparities in the availability and as well as the known ability, for lack of a better way to put it. Kind of talking about how there's certain programs that are available to the entire state that maybe somebody in Beaufort, North Carolina is not privy to, or somebody in, even somebody in Cary, North Carolina is not privy to, and it's right there kind of in the available to them. And then another big thing is the lack of statewide certification. So we talked about how one person may be overqualified or very qualified, another person may not be as qualified, but because it's not standardized, they're able to get by. And so you're not able to basically give people equal resources, so to speak. And what I mean by that is somebody who might be bilingual or trilingual or polylingual, maybe they can technically help somebody who is speaking, let's say, Spanish, but maybe not to the degree of somebody else. And that's why you need that standardization. And then, of course, the absence of medical reimbursement is huge because, unfortunately, in the American health system, reimbursement is kind of a big driver into our health systems. Especially people who have consult services, for example, a lot of times they're driven to use those consults because it gives the hospital money, right? And so it works in a clinical setting as well. We all know these things. And basically, if we could get more reimbursement for interpreter services, I think we could definitely see a lot more. And we already talked about advocacy of comprehensive state level investment in policy standardization, and specifically kind of establishing some of the things we talked about that maybe could help. For example, the standardization of the certification and the reimbursement, as well as getting standardized like training programs or what's the word? Excuse me. Uh, Not published. Sorry, I'm in the NICU, so my brain's a little fried. Um, oh my goodness. Investing in training programs, excuse me. And in general, we feel like North Carolina should foster a healthcare environment where everybody, no matter where they come from and no matter what they speak, should be able to have not just equal but equitable and access and quality healthcare. Next slide. And are there any questions from the group?
Fantastic. Thank you all. We can unshare the slides, Erica, if you're able to kind of see everyone. Great, great job. Questions for this group? Thoughts, reactions, comments? What do y'all think?
It's Cormac. Sounds to me like maybe I didn't understand everything, that you could do this as at a national level. You know, we use iPads in our clinic, which is the same equivalent. So you don't have to have the physical people there. That'd be number one. And getting a kind of a national, everybody working together, get a national grant to just do it through a foundation, I just think might be idealistic, but more practical. The other part, whether their past medical history, and I have limited experience. I work in an underserved clinic about once a month, but they could get their documents translated. And if there was a phone with Google Translate, it's nice to go through the translator, a bit cumbersome, but I've always wondered if, back and forth, you could have more control over the setting. In other words, just put in the two languages and hand the phone back and forth to each other. Because I think although
This is a
if
great question, Dr. O'Donovan. I think to this group, one of the questions that's coming up is the tension between access and quality. Like technology offers this great access, but like I hate the iPad just as much as you, Cormac, because it's like not all the cultural aspects, all
yeah,
the intonations and things. For this group, like what was your sense as you researched this, as you looked into this? Like how did you wrestle with the expanding access through technology, but feeling like you're losing that quality? You talked about standardization and those things. Like, what's your sense? Like, how do we move forward? What's the right way to approach it? What was your sense, team?
Yeah, I think you hit on some of the points that we are advocating for, where there should be some kind of regulation over to make sure that all like languages get equal like quality in terms of the services offered. And like we mentioned, some of the refugees come from places where their spoken language isn't as widely available here. And so that poses a problem. So you just don't have those interpreters, those live interpreters available on site, or even like with the iPad, like you may need to like request it a couple of days in advance. So that's like additional burden on both the patient and on like the healthcare provider in the facility that is trying to offer these services. Um, yeah, that's my sense of it. And even just like from practical, like, just like clinical experience, like even using the iPad is a pain sometimes. And like, you never know what kind of quality of interpreter you're going to get. And there were times where we were like yelling at the iPad for them to be able to hear us and like back and forth. And it doesn't necessarily make for the best type of conversation. And so that's always frustrating. And I know that patients have sometimes just like used Google Translate to like share something with me just because that's easier. But I do wonder what like I'm missing out on because like or what I'm losing out on in terms of the cultural nuance because of that.
To add on to
Oh, I like that we said the same exact thing. Go ahead.
to add on to what Julie just said with a personal anecdote, I actually just came from clinic. I am currently on cardiothoracic service, and the attending that I was working with this afternoon had a patient, or second to last patient, because of how long this visit ended up taking. She's an immigrant from Venezuela, and she has a ascending aneurysm that needs to be replaced. And it's just, oh my goodness, I wanted to pull out my hair with how inefficient the interpretation was going with the iPad. I think there's some connection issues, so they were having trouble hearing us, and then our interpreter this time is a little slow to interpret. And I understand because it's kind of hard to pick up on the cues of everyone. It wasn't just like the provider, me, and the patient. It was also family members also in the room, so it could be hard to hear. And it's just there were definitely things that were missed in the conversation. And I speak decent Spanish, but not I can't interpret myself. Um, so it was really frustrating to be in that position and to also at the same time hear certain things being missed. And ironically, like previous to the visit starting, I had asked, hey, like we have in-person interpreters. How do we get like in-person interpreters here? And I was told by this is like my second or third time in clinic, so I'm still fairly new. And I was told, oh, well, that might take too much work. We have to page them and then we have to wait for them to come around. So let's just use the iPad. So I was like, okay, all right. But at the end of the visit, I felt like the visit would have gone so much faster. There would have been so much more understanding. We wouldn't have had the puzzle look on our faces like as many times as we did. And the patient would have walked away with a better understanding. And it's an aneurysm, aortic aneurysm. It's a pretty serious condition. With a much better understanding of what she needs to do to make sure that, it doesn't lead to a dissection or a rupture. But
Really important story. Queena, thanks for sharing. Raina, what did you want to add?
I just wanted to say, I guess, like, and also adding on to that, at that interface of access and quality, I think the best that we can do right now is to kind of, with those iPads and with those innovations that we still have that are getting better and better. So with AI and with all these different ways that we have to interpret things that don't necessarily need you to directly say it. There's like it's a crazy amount of innovation in that field. But I think that if we're going to improve anything, and if we can't improve the access or standardize the access as much as we'd like, if that's not realistic, the best that we might be able to do at the moment is just making sure that we get that tech out as much as possible. And we're lucky to be able to do that.
And I just wanted to add on to what Queena was kind of talking about. She kind of made a good example of how the standardization, right, of these services can basically determine whether we have more interpreters who are at speed, so to speak, with interpreting, right, and accuracy, but also and I guess we didn't mention this, but I guess I kind of thought it went without saying, but let me just go ahead and say this. We ourselves as healthcare providers also probably should get some sort of training as well, right? In how do we speak to interpreters? Some of us, in medical school, we're taught, or, in different professions, I'm sure we're also taught to ensure that you're speaking in a way that the patient can understand. And some medical interpreters, they're tracking all the way, right? You can say, the aneurysm, and they know how to simplify it themselves. Whereas there's other interpreters who they're just gonna say there's no translation for it, so they'll just say that word, and then now the patient's still kind of lost, right? What does that mean to them? If that makes sense. And so I think this is another one of those situations where sure, the access is there, but again, it's that quality, and that quality is kind of, I won't say it's more important, but in some ways there is undeniable significance to it.
Yeah, I mean, this is a great conversation. It's just reminding me of how intimately communication is linked to quality of care, and quality of care is linked back to communication. You can make the right decision, but if it's not conveyed, communicated in a way that's effective, right, everything just falls apart. And so this was a great discussion. I do want to keep us somewhat on time, so we're going to move to the next group. But thank you all for tackling this problem. It strikes me as we conclude this conversation, this is an advocacy topic every single one of us can take to the clinic tomorrow. And I mean, we can choose to do the right thing or a challenging thing, or, Queen, as your conversation led us to really, address the needs of the patient at the time. It's also something where these individual stories are really influential to legislators and to others that are making these decisions. And those like patient-specific stories that you're having can be highly influential. So Great topic, great presentation. Thanks for presenting and kicking us off. That was great. We will move to the second group, who's clearly got the best title. So start off with a bang. Love this. Floss, brush, rinse, and repeat. And so we'll turn it over to this group.
Hi, everyone. Hope you all are doing well. We are presenting Floss, Brush, Rinse, and Repeat, addressing Harnett County's oral health disparities. I worked on this project. My name is along with Jordan Poe. She is a fourth-year pharmacy student at Campbell University. Madeline Clayton, we call Maddie. She's a fourth-year medical student at Campbell School of Osteopathic Medicine. And myself, Asia Lorraine Walker. I am a third-year medical student at QSOM as well. Next slide, please. Okay. So our challenge is that oral health is vital for overall health, yet it has limited access to dental care, recognized as a social determinant of health, and it affects outcomes in North Carolina, particularly in Harnett County. Key factors include transportation, housing, environmental conditions, poverty, and access to care. In our county and even in our state, patients face challenges such as disproportionate dentist-to-patient ratios, funding and insurance issues, and fear of dental procedures. These barriers prevent consistent and affordable dental care, leading to potential systemic health problems such as heart infections, diabetes, and sepsis. The goal of our project is to examine the impact of social determinants of health on dental and systemic health and propose solutions to enhance dental care, information, awareness, and clinical services in Harnett County. Next slide. So right here is a snapshot from 2020 of North Carolina's oral health snapshot state totals. And some things we want to highlight then in adults at 30.3% of pregnant women in 2020, they had untreated tooth decay. 45.5% of adults age 18 older has had permanent teeth extractions, and 17.4% of adults age 65 years and older have all of their permanent teeth extracted. Next slide, please. And so that's important because if you're oftentimes, and especially me being in medicine, and also Jordan being in pharmacy, we may talk about the body, but oftentimes oral health is not often talked about a lot because we're often putting it into dental care, dentists, hygienists. And so the reason why it's so important that we wanted to highlight and bridge together interdisciplinary of the oral care is because when your mouth is essentially the window to your body. And so for instance, cardiovascular disease, you can be introduced by different microbes in the body. Fibrosis, often streptococcus can impact your body, as well as Pseudomonas with pneumonia. So we want to really highlight how different microbes or why it's important to talk about the importance of oral health. So access to dental care in North Carolina and Harnett County. In North Carolina, only 56% of adults have dental insurance, and about 13% haven't seen a dentist in over 5 years. And Harnett County is a rural area with high poverty rate, faces significant challenge in accessing dental care due to limited insurance coverage and inadequate transportation services. Many residents rely on Medicaid, which offers restricted transportation. And so one of the things we talk about a lot in our program with social determinants of health, and also in our various backgrounds, we want to look at how literacy and oral health may tie into each other. So with low literacy levels in Harnett County, only 57.3% of females and 47.2% of males have proficient reading by third grade. And this also links to poor oral health outcomes and awareness and practices, because if you don't understand certain implications or can't read certain health literature, you don't understand may lose the importance of why you may need to do certain practices or be able to have different access to different specialties. And also, if you don't have a high reading level, it can impact your ability to have certain jobs that will afford different insurances so that you will have this access to different access to dentists or other health care. And so also financial constraints and limited access to dental clinics further exacerbates oral health disparities. And North Carolina's shortage of dentists also perpetuates low participation in Medicaid compounds these challenges. Next slide, please. So moving forward, a bridge must be created between patient education and interdisciplinary standards of health clinicians, students, and policymakers. Our three-pronged approach intervention to address these issues in Harnett County specifically are outlined in the following slides. So these are our three action steps. One, developing and integrating oral health education into professional health curriculum. Two, identifying and supporting champions. And three, advocating better integration of oral health policy and access. So our first one, developing and integrating oral health education into professional health curriculum. So at our school, at Campbell, we see the importance of we're required to do interprofessional education like once every semester, like we call semesters, so that we can understand kind of what different professions do, how we can work together collaboratively to help with improving patient outcomes. So we believe that dentistry and other health professions, particularly medicine, often have separate education curricula, resulting in limited health exposure to oral health. Medical students receive oral care training, where dental students study the structure and function of the entire body. This lack of exposure to oral health microbiomes put non-dental health professionals at a disadvantage in identifying and preventing oral cavity diseases connected to systemic health. Incorporating oral care curriculum to interprofessional education can expand knowledge on systemic health consequences. Next slide, please. Effective interdisciplinary collaboration improves health outcomes. We want to utilize Harnett County University's health sciences programs to establish an oral care curriculum that can prepare future providers to advocate for their patients. In North Carolina, universities like the University of North Carolina Chapel Hill medical and dental schools have integrated oral health education in their medical curriculum to address and reduce oral health disparities. This model can serve as a framework for other colleges and programs in Harnett County, such as CUSON, which is Campbell University School of Osteopathic Medicine, and East Carolina Dental. So with that, in Harnett County, ECU has dental school has a clinic that is situated within Harnett County, and as we know, ECU's main hub is in Pitt County. So maybe we can try to work in tandem to see what we can do to work together so that we can see how we can bridge having access for individuals who may not have access to dental care, especially with our Campbell University Community Care Free Clinic. Collaboration between dental clinics, public health, and medical professionals can create comprehensive instruction for health professionals to include oral health exams and lesion identification, documentation, and also allowing for timely referrals. Next slide.
Our second action step is identifying and supporting oral health champions. By implementing community education, innovations, and research in Harnett County that can significantly improve the medical and oral health continuum. State and community partners, including universities, health departments, clinics, NCDHHS oral health divisions, and area health education centers must work cooperatively. This can be further enhanced by champions who promise to promote community needs. These champions can leverage partnerships to incorporate statistics, patient stories, and reveal community-specific oral health topics. They would need to be chosen through rigorous selection processes to ensure proper education and time put back into the community. So these champions we would consider to be volunteers, of course, dental students, dental hygienist students. So there are a lot of different opportunities for community champions to show up for our community. Next slide. Training would provide champions the ability to conduct needs assessments, interpret oral health metrics, and provide safe environments for community feedback. This training would include oral health access, disparities, and social determinants such as health equity, racial bias, and social justice. Champions could expand their reach through in-person and online presentations, disseminating brochures and QR codes for oral health support and information, and designing curricula. Next slide. Our last proposed action step is to advocate for better integration of oral health policy and access. Medicaid benefits have limitations and exclude critical dental procedures like non-IV conscious sedation, TMJ splints, and fixed bridge work, which can cost up to $10,000. Medicaid reimburses dental services at an incredibly low rate of 34 cents per dollar, leading to only about 45% of dentists participating in Medicaid programs. So it's crucial to address reimbursement rates so that we can encourage more dentists to accept Medicaid patients. Teledentistry ensures care, reimbursement, and documentation standards that are equal to in-person visits, thus enhancing accessibility for those facing barriers and disability and transportation issues. By increasing government funding for dental workforce development, we are serving underserved communities. So, for example, Blue Cross Blue Shield of North Carolina awarded a 2-year, $1.8 million grant to the North Carolina Oral Health Collaborative to increase access and equity in oral health care in North Carolina. Next slide. It is also imperative to organize public health campaigns targeting children, adolescents, retirement communities, and underserved clinics. Simple messages about oral hygiene practices should be spread via social media, flyers, and local news. Mobile dental clinics and school-based dental sealant programs offer affordable dental care, and they're essential for reaching rural and underserved populations like prisons, homeless shelters, and elementary schools. These models have been supported by studies done by Lennert and Thicker. These school-based programs significantly benefit low-income families and their children by reducing tooth decay and increasing accessibility to cost-effective dental care. Next slide. So in conclusion, tackling socioeconomic factors, geographic disparities, and cultural barriers is crucial to improving dental care in Harnett County. Increased tobacco use and limited transportation access are significant challenges that impact dental hygiene and overall health. By integrating oral health education into healthcare curricula, training community oral health champions, and expanding Medicaid benefits alongside teledentistry and public health campaigns, we can work together to bridge the care gap. Policymakers should focus on expanding Medicaid coverage and reimbursement rates for our dentists, supporting teledentistry, and enhancing workforce development. Collaboration between medical providers, community organizations, and policymakers is key to reduce dental health disparities and improve outcomes. Next slide. Thank you guys for listening. What questions do you have for us?
Great presentation. What questions are out there? One question I have for the group, Manisha's got one. Yeah, Manisha, what do you think?
More of a statement than a question. I was just really pleased to see when you laid out your sort of three-prong approach that the first one sort of started very upstream with the education of health professionals and dental professionals. I just thought that was a great place to start. So many times we jump to number 3, but it was just nice to see number 1 there about the integration of health and dental care. So thank you. Thank you all.
Yeah, great point.
Thank you.
I mean, you all have summarized this problem so well. I'm interested of those that are listening and thinking about this. We could spend the next 2 hours talking about gaps that exist in oral care and the impact on patient outcomes. Who's seen this done really well? Who's in a training program where you've really had a great experience, with how this was emphasized, taught, incorporated into your training? Any great successes out there for anyone?
I'm not in dentistry at all. Clearly, I'm in pharmacy, but I'm from Maryland, and I went to the University of Maryland College Park for undergrad. And at the Rockville campus that we have, there's a like a free program basically, and I think it's Medicaid based or income based. But the dental hygienists that are training at the University of Maryland, they travel to Rockville every so often, and basically they hold clinics like, I don't know if it's one day a week or a few days a week, but basically they like sell out, you know, because you're giving your patients who can't afford much free dental care. So, and I know it's still going on. So I think that's really a successful story. And I'm not really talking about education, but clearly they're taught in their education to give back to the community. They're taught, you know, like how to work with patients who have low income, of course, that, you know, may not speak the same language as you. So really just providing that care for our patients, and like starting that in the classroom and implementing it so well to where you like can barely book appointments is awesome.
That's phenomenal. Donnell's there. He's going to now refer all his patients. I think that's a great connection. Thanks
I
for
think
sharing.
I think with us doing this project, I was on rotations, but I only did a fourth of my rotation. I had to do an immediate vacation for a medical issue. But I was on endocrinology my very first rotation, and a lot of individuals living with diabetes. And I always made sure to look at their mouth, just to see if there's any issues with dentition, any abscesses. There's stuff that they may not think about because they think it might be something regular. Because a lot of times, if you have pain, like my issue, if sometimes don't know you're sick until you get well. And so they might think this is normal. Having this pain in my tooth is normal. Having this, because they've always had it, and you become as essentially numb to it or get sepsis. So that's one thing that with working with these ladies, I made sure to try to integrate things that I'm learning about on my own to try to make sure I'm doing it so I can be a better clinician.
That's so interesting. Thank you all for this presentation. Manisha started with very upstream. I may end us with this conversation very downstream, right? These first two presentations are aspects of social drivers of care that influence the patient in front of you and in front of me. And like we have agency. Every person on this call, every healthcare provider, has agency to make some movement and some change and positive outcomes for patients on this. This is not solving food insecurity, which we may talk about, or housing challenges which may occur, or insurance status. Right. This is something kind of right in front of us every day. So thank you all for shedding light to what is a just critically important driver of health that where there's just a huge gap. So you all did a great job. All right, we're going to keep moving. Thank you all for discussion and engagement. We'll move to our third group discussing this great topic, impact of concentrated animal feeding operations. I'm going to learn about something new. Maybe many of us will on environmental and health related disparities. We'll turn it over to this group. Excited to hear what you all are going to present.
Alrighty, good evening, everyone. Our group first had an interest in environmental effects on health-related disparities and decided to hone our topic in on concentrated animal feeding operations. So if you'll go to the next slide, please. This is our team. So the people that worked on this project are myself, Tara, Hannah, Mia, Emily, and Marissa. And if you go to the next slide. Thank you. So through our research on this topic, we found that CAFOs, the concentrated animal feeding operations, specifically in North Carolina, pose major environmental health challenges. These facilities confine large numbers of hogs and poultry, which can cause significant pollution, and pollutants that come from these facilities include ammonia, hydrogen sulfide, particulate matter, and other pathogens. Some of the adverse health impacts caused by these facilities include respiratory diseases, gastrointestinal illnesses, and increased mortality. And we also found that the marginalized communities are disproportionately affected by these diseases and these pollutants. So our research explores the disparities and proposes solutions for environmental justice regarding this issue. If you go to the next slide, oh, sorry, one more back, please. Thank you. So throughout this presentation, we are going to answer these questions for you. What is a CAFO? Why are we concerned about CAFOs? And then finally, what can we as future clinicians do about CAFOs and their effect on our patients' health? And I'll pass it to Emily to get us started.
All right, we can go ahead to the next slide, please. So to give some information on the background of CAFOs, or concentrated animal feeding operations. So CAFOs are an industrialized farm that came onto the scene in the 1970s or through 80s and rose in popularity incredibly quickly. They are basically a conveyor belt for pork products, which is why their more popularized name is factory farms. These places are loaded with technology and developments, including robots, temperature sensors, and GPS technology to get the lowest bottom line and maximize profits. And it's very effective. In the state of North Carolina, the pork industry brings in around $10 billion in economic output each year, and it generates over 40,000 jobs. These are not cute little family farms. They're really factories, and the following slides will lay out why we consider them to be such a harmful problem for our communities, our environments, our patients, and then what we can do about it. Next slide.
Okay, so why are we concerned about CAFOs? You can go to the next slide for me. All right, so one of the big concerns is waste management with CAFOs. Most swine CAFOs store their manure in open air lagoons. Often they are unlined and can leach waste products into the ground. Lagoons may overflow during major precipitation events. As we recently saw this past week, North Carolina is prone to flooding with our hurricanes. And most of these farms are located, you'll see later in a map, kind of in low laying areas. So definitely predisposed to flooding. And then waste evaporates, forming air pollution that may precipitate back to the ground, contaminating water sources. And a facility of 2,500 swine may generate an estimated 26 million gallons of lagoon liquid, almost 1 million gallons of lagoon sludge, and around 21 million gallons of slurry. So that's just like the different consistencies of this waste product in the lagoons. And this is over 1 year, which really puts it into perspective how large these farms are. And spray field system is a popular method where lagoon waste is sprayed on fields for fertilizer. It's kind of looked at as like a repurposing method, but at the same time, they're aerosolizing all of this waste that's been stored in these hot lagoons sitting in the sun. So there's definitely potential for travel for many miles, depending on weather conditions, to local communities. And then also, this is a big focus on swine CAFOs, but there are also poultry CAFOs, which is typically chickens, and they dispose of their animal waste using a dry litter method where they spread it out onto fields. But with the wind, that also aerosolizes it, and with any rain, it can also contaminate any water sources. Next slide, please. So some of the major things we're looking at in this pollution from CAFOs is one is bacteria. So there was a study that looked at water quality downstream from swine farms in Duplin County, and that overall 40%, 23%, and 61% of samples exceeded state and federal recreational water quality guidelines for fecal coliforms, E. coli, and Enterococcus, respectively. And then excess micronutrients like nitrogen and phosphorus encourage harmful microorganisms to grow. And then another aspect to look at is antibiotics. A lot of these farms really use antibiotics to try and keep their animals healthy in these close-knit environments and keep any disease at bay. So a study that looked at CAFO air samples in the area where all the animals are stored, and they cultured the samples and looked at their susceptibility to antibiotics. They looked at erythromycin, clindamycin, tetracycline, vancomycin, and virginiamycin. Virginiamycin is one that's used in cattle, so you guys might not recognize that one. And so vancomycin is the only antibiotic in the above that is not approved for livestock use, so it's not used. 137 were Enterococcus species, 44 were coagulase negative staph, 45 were viridans group strep, and then one was Micrococcus luteus. So all of these isolates were still susceptible to vanc, as that's not what is used in these farms. But 53.3% were resistant to at least 2 of the antibiotics used above, and then 50.6% were resistant to to 3 of them. And then one other big pollution aspect of this is particulate matter and the gaseous irritants. So particulate matter is increased around CAFOs due to large quantities of pet dander and waste. The particulate matter can act as a carrier for toxic components in the air, like the bacteria we talked about, endotoxins, or ammonia. And so CAFOs are associated with increased ammonia, hydrogen sulfide, and methane in the atmosphere. Next slide, please.
So regarding specific health effects, as Marissa discussed, the ground application and storage of untreated manure can result in runoff or leaching into groundwater, which can lead to viral contamination or nitrate poisoning of drinking water. And air pollution is another significant health effect, as the inhalation of pollutants and toxins can cause systemic effects, lung inflammation, asthma, bronchitis, decreased lung function over time. CAFOs are known breeding grounds for insect vectors such as houseflies and mosquitoes, which can also spread bacteria and zoonotic diseases. Here's just a table showing some of the typical pollutants found in the air surrounding these CAFOs. Sources include manure, feed, bedding materials, animal dander, but the health risks are primarily respiratory, but can also include skin and eye irritation, olfactory neuron loss, toxic syndromes, and for hydrogen sulfide, even death. In North Carolina, hogs produce over 9 billion gallons of manure each year, and 360,000 homes in North Carolina are estimated to be within 3 miles of a hog CAFO, which is likely underestimated today. Most of these are concentrated in rural and predominantly low wealth minority areas. And all of these communities exhibited higher rates of all-cause and infant mortality, as well as increased mortality due to anemia, kidney disease, tuberculosis, and septicemia. This doesn't necessarily establish causality, but it is a representation of the disparities in these communities. One study found that children attending schools within 3 miles of a hog farm had more asthma-related symptoms, wheezing, asthma diagnoses, and asthma-related medical visits than those attending schools farther away from a hog farm. And again, although this study didn't specifically establish causality, it's significant enough to warrant further research about those effects. This is a visual representation of the elevated disease and death risks in North Carolina communities in close proximity to hog farms. Next slide, please. And as we mentioned, the health impacts of the CAFOs disproportionately affect marginalized communities who are more likely to live near these facilities and have less access to healthcare and resources to mitigate these risks. They're primarily located in areas with high percentages of Black and Hispanic populations, high poverty rates, and low levels of education. And the proximity to CAFOs and intensity of odors also correlates with economic disadvantage. The areas in North Carolina with the most CAFOs are Duplin County, Sampson County, Alexander County, and Union County, which are highlighted on this map. And you can go to the next slide. There are some tools online that show the distribution of CAFOs throughout the country. This one is a map from the North Carolina Department of Environmental Quality showing the CAFOs in North Carolina. The yellow dots are the swine permits, so you can see how significant that is in those certain areas. And this is a screenshot from the Environmental Working Group's interactive map, which you can access online, showing the CAFO data in various counties. And that dark red one kind of towards the bottom is Duplin County. It shows us that there's 760 CAFOs, 12,489 residents within a half mile of a CAFO. And there's also high levels of waste output, over 18 million animals, including over 2 million hogs and pigs, and 865 waste lagoons just in that county. So why are they disproportionately cited in these disadvantaged communities? There's a lot of reasons, but some of them include historical patterns of land use and socioeconomic segregation, making land in these areas more available and less expensive, environmental racism, limited resources and access to protective measures. Some examples I put here are, for example, in these areas, people might have a lack of air conditioning, which results in them opening their windows to get more air, which could increase exposure to harmful pollutants. And these people may also have higher rates of pre-existing chronic diseases and limited access to healthcare, which can exacerbate the adverse health outcomes associated with proximity to CAFOs. And I also wanted to share this map, which I thought was interesting, of North Carolina's industrial hog operations in 2014, overlaid on the density of North Carolina's enslaved people in the 1860s. So I thought it highlighted the environmental racism and long-standing patterns of racial and economic inequity.
Thank you, Mia. So I guess the next question is, what can we do as future clinicians to be more aware of these problems and solve them? And that's what these next slides are for, the solutions that we came up with to solve these problems at Cathos. Next slide. So the first one that we thought about is, what can we do as healthcare workers? Something that we often already do in our clinics is screen people for obesity, for exposure to various things. So why not add a screening tool for exposure to CAFO? So that's what we have done. Thank you, Mia, for putting this one together, but we made a specific screening tool, and there's actually a link to it on the slide. You can use that QR code to this simple tool, a printable tool that you at your clinic could give to your patients while you're signing them in, along with those other screeners that we do, like the depression, all those other things, just to get an idea of what patient populations are at risk and to maybe start just being aware of the exposure that some of these populations are getting. And as somebody who currently lives in Eastern North Carolina, with all those maps that we just saw, I think this would be very relevant in the clinics that I work in, but could be used anywhere because, as you saw on the map, there are CAFOs, various parts of the state. Next slide. And this is just a picture of that screening tool that we made. If you already did the link, you can see it, but just a bunch of different questions that ask about those exposures that we talked about. Next slide. So the other one solution that we decided to propose is agricultural solutions. So as my colleagues highlighted, there are so many wasteful practices in the current agricultural system that we have. And here we propose a few different things that might help improve these practices so that they're less dirty and cause less health problems and other things in the surrounding community. So some of those are transitioning to more organic farming or agroforestry to promote biodiversity and reduce waste. Another one is integrate sustainable livestock management practices like rotational grazing to make sure that we're not just generating a bunch of waste in this one place. And maybe we can decrease the waste that we generate in a smaller amount of time. And another is just supporting local and small scale farming, because it is this large scale farming that is causing so many of these problems, because our demand is so big for a lot of these things. That's why the industry is making these solutions of CAFOs to meet that demand. Next slide, please. And our last solution, and one that's a little more relevant to the North Carolina Medical Society, is advocating on behalf of changes like the ones that we just talked about. So one that we would like to propose is advocating for stricter regulations on CAFOs to reduce their air emissions and waste management, and to protect the health of the individuals who live in those communities. Another is to implement like a comprehensive environmental impact assessment to ensure that these CAFOs are, in fact, not being put in communities that already suffer from bigger health conditions, poverty, other things like that that make these effects worse. And another one is to enhance the regulation of these CAFOs so that we can't just put them anywhere, that there are stricter rules in terms of their waste and all the things that they generate. So I think advocacy is one that we were talking about downstream causes and downstream solutions. This would be a really great one to maybe, it won't decrease the number of CAFOs that exist, but maybe it'll improve awareness and make it so that we can't have as many in the future. And even just bringing it up to your legislature, a lot of them, like, I didn't even know about CAFOs until this project started. And that's probably the same with a lot of those. Next slide, please. And related to that, I don't know if any of you have ever been to like White Coat Wednesday, but
One thing that is super helpful is knowing your argument, having stories about maybe individuals that were affected by these things, but also we put together this resource, just a one-pager that once you have those conversations with your legislatures, you can give them this as a follow-up because it summarizes all of the arguments that we made in this presentation and then gives them those solutions that we were looking for. So the link to download that is actually in the slide. I know there's no QR code, but if they want to share these presentation slides, it would give everyone access. Next slide. And that's pretty much it. That's a QR code link to our references. Thank you guys for listening. Any questions?
Oh, thank you all. It was tremendous. I mean, I love this. I learned more than I have ever known about this. So this was fantastic. Any questions?
Just a comment. I'm Dr. Coppola, Campbell University Internal Medicine. Work with Marissa. Excellent job to all of you. But so it sounds like the evidence for harm is not the issue. It's clear evidence it's harming communities. It also sounds like the amount of resources these CAFOs have is also not the issue. They have billions of dollars. It sounds like the issue is the political will to protect people and communities. So there is some precedence for this. As I was hearing this presentation, I thought about how leaded gasoline was banned, and a similar grassroots problem was identified, scientific evidence grew, and then finally it was brought to the legislative level and it was outlawed. So my sense is, and I think it was excellent that you showed the superimposed areas where the CAFOs are and these economically and socially disadvantaged communities are. I mean, they're on top of each other. I think the only way this is going to get fixed is through legislation, personally. So I think physicians need to make their voices heard for issues like this. Very important. So great job.
Following that, Laura, your comment in the chat, very similar, could be highly beneficial in primary care. Survey results could be critical in advocating for this. I mean, this is just something that no one's talking about and everyone's, is sort of hiding underneath the radar. Dr. Coppola, as you just said, where, you all as clinicians and future clinicians have an ability to shed light on this. Hannah, we will share the slides. This resource you made is extremely valuable. Have you done White Coat Wednesday? Do you mind describing that for the group?
I was able to go to the FMAS, the Family Medicine Advocacy Summit in DC. And that's one of the big takeaways I took from them is that they had these, like the argument organized. It wasn't really about us discussing what we were going to talk to them about. They had it laid out and they had those one pagers for us to give to our legislatures, the people that we spoke with. And I thought it was a very organized way of, look, here are like the background points, and most importantly, here are the solutions, because they talk to so many people a day. Giving them something that they can read, they can follow up on really makes a difference. And everyone having the same resource, you taking that to multiple, like say you have a different representative than I do, them all having that resource makes it a lot easier to bridge the steps it takes to make that in the legislation.
Fantastic.
So I thought, and making it look pretty, even better, because they don't have time to read that. As long as they can find the important information.
All right, two quick questions. Sophie first, then Cormac. Oh, Sophie, you're muted.
Thanks. Yeah, I didn't really have a question. I just wanted to jump onto that White Coat Wednesday advocacy topic. I work really close with our political activism team at NCMS. I just went to the White Coat Day. I think it was about 2 months ago. That handout is critical to getting your point across, because them seeing your face is probably the most impactful it can get, but you being able to hand them a document that they can give to their legislative aides that is later going to do the work for them is super important. So my Campbell team, we're highly connected with Duplin County and Sampson County. I think that's a great tool for us to use. But just to give everybody an option, they just made your job 1,000 times easier if you want to be an advocate for this topic. Great job, guys.
Because you shared the link. Fantastic. That's a great resource. Cormac.
Great presentation. It just it might be a long answer, but I heard that making these factories smaller would be part of the solution. How, if I'm one of these factories and I say, well, I'm not financially viable, how does both teams meet together, the health and the profitability? Or can you make an argument if I own one of these factories, yes, I'm making money, maybe it isn't good for health, but how do you propose addressing these factory owners to say make it smaller and worthwhile? I mean, it's probably not the same thing, but in Ireland they ask them not to overproduce certain things because it sounds funny, but they ask them not to overproduce certain things, milk, livestock, or to bring
That's
down the
a
price.
fantastic question. Thank you for asking. Because I feel like it's definitely one thing that we didn't really touch on is that the people who own these factories have to make money too. And I think that might not necessarily be something that we can fix, but as consumers, and that's why we put in like maybe supporting more sustainable agriculture as a consumer. If we shift the demand to things that are produced in a more ethical way, I think that's somehow a way that we could affect those. But at the end of the day, I don't think one person like me or you will affect how a factory decides to run its business. But we as consumers can shift the change, and legislation forcing these factories to do certain things can change. But thank you for that great question.
Great question, because that is advocacy, bringing people together. Emily, did you want to add something to that?
Oh, I was just gonna add, like factory farms are kind of an industry, and industries can be regulated by governments. And I think it is just about making sure that legislation is passed in order to regulate the industries, just the way that other industries are regulated.
Yeah, great points. A lot of discussion. Sounds like we could go on for a while, but I am looking at time. We want to be respectful for other groups. Great presentation and great topic. Thank you all. So we'll move to our next group. Excited about this topic about food insecurity, problem solutions, teamwork. Turn it over to this group.
Thank you. So my group consists of Michael Denning, and he is, I think, in his fourth year of med school, and Ben Wise, who is in his first year of psychiatric residency in Greensboro. Next slide, please. So our problem statement is this: North Carolina does not provide school meals for all children. Legislation has been brought to the North Carolina House and Senate. However, these bills have not made their way into law. In the absence of top-down policy implementation, 2 counties have set up programs to get school meals to all children, Buncombe and Wake counties. We propose to use Buncombe County as a model for the rest of the counties and seeking to provide school meals to North Carolina school children. Next slide, please. So we decided to look at food insecurity from the perspective of advocating for school meals for all children. And there are also a couple of terms that we wanted to define before we go forward that will help to understand the rest of the presentation. So the first one is acronyms and terms. First one is CEP. We'll be mentioning CEP quite a bit, and that stands for Community Eligibility Provision. And what that is all that means is that the school has full provision for school meals, or another way to put it is universal school meals, or they're basically a school that has full community eligibility provision, provides all school meals, breakfast and lunch, to the students at no cost to the students or the parents. So just keep that in mind. You may hear community eligibility provisions, CEP, universal meals, or school meals for all. Those all mean the same thing. Another term that I want to define is identified student population, or ISP. And that means those are the students who are identified as the students that need to have access to reduced or free meals at their school. And how they define the identified student population is through SNAP, which is the Supplemental Nutrition Assistance Program, which is formerly known as the Food Stamp Program. And it's a federal government program that provides food purchasing assistance at low or no cost, assistance to low or no income people to help them maintain adequate nutrition. That's one of the qualities that they use, or metrics that they use to determine if a student qualifies in the identified student population. They also use some other things too, like if their household qualifies for Medicaid, and also the income. But I just wanted to start the presentation with that information because, again, it will come into, you'll hear these terms throughout the presentation. Next slide, please. So just want to give you a little background. Food insecurity is defined as the lack of consistent access to enough food for an active, healthy life, and it affects millions of children across the United States. And we just wanted to start with that just to kind of show the national impact and then kind of drill down as far as North Carolina. So the next point is, according to the USDA, in 2021, approximately 12% of households and about 9 million children lived in food insecure households. And that, again, is for across the country. The impacts of food insecurity on children are profound and multifaceted. When children don't eat, they have difficulty concentrating, and if they're at school, they need that brain power to be able to carry on and learn. And specifically in North Carolina, food insecurity among children is about 16.2% of households, which is higher than the national average. Next slide, please. So as I mentioned in the problem statement, we chose to look at Buncombe County. I did mention that Wake County also has full community eligibility provision, or universal meals, but that came along recently. That came along within the past maybe month or so. So we did not focus on them. We focused on Buncombe County. That's who we've been working with since the beginning of this program. So we met with the school nutrition director on several occasions to talk about what exactly they did and how they were able to provide full CEP for their county. Because again, out of the 100 counties in North Carolina, they were the only county at the time that had full community eligibility provision or universal meals. And when the decision was made to go full eligibility provision, it was after the pandemic, and the pandemic led to an increase in the percentage of the identified student population. So meaning more students were living in poverty and more students were coming to pick up the free meals that they were able to get during COVID. And these students are the ones who are, again, eligibility for the free or reduced meals. And as far as also in regards to the eligibility, if a school is 25% ISP, so 25% of the identified student population, then it qualifies for CEP, or the community eligibility provision. And last year, which is when the program started, there was only one school out of 45 that did not qualify. So they decided to make that one school universal breakfast and lunch as well. And by doing that, they created full CEP for the county. So I would just want to emphasize that all of the schools, for the most part, 45 schools, out of those 45 schools, 44 of them, they already had that 25% student ISP, which allowed them to receive full community eligibility provision. So it was basically a matter of supplementing one school to then have school meals for their entire county. As far as the budget, they're still doing the numbers, but they said that it's costed them about $14 million, and they spent an estimated $7 million on food. But they also, and some of the other funding was supply chain money that came from relief funding from the state. And there was also local to farm school money, which was a grant that helped offset the cost of fresh fruit and vegetables. And they also had their own money from their budget from the revenue of sales of just the meals itself. And let's see. The next thing that I wanted to go into, oh, I'm sorry, go back to that slide really quickly. Thank you so much. I wanted to highlight the results. They lost money this year, but they plan to increase participation next year. And they were able to do this because they have very good management, a very good management team, and they run at about 40 to 45% cost of food, labor, and supply. So therefore, they were generating more revenue than expenses until this year. So they kind of had a little bit of buffer there, even though they lost money on this year of doing the universal school meals. And they are planning to increase the participation by doing certain, there are certain things that they're going to do, like doing a food cart and taking it around to the classes in the morning for breakfast. So trying to bring the food to the students, and then also taking it out to the buses and stuff. And if they're able to increase their participation, then even more than they have already increased it, then they should be able to continue on with providing the universal school meals for the county. Next slide, please. So the proposed solutions, we decided that the best way to do this would be several different things or several different pathways to achieving school meals for all in North Carolina. One is creating a how-to handbook as a tool to help other school nutrition directors across the state on how to move forward with universal CEP for all the counties in North Carolina. And that toolbook would include how to do your budget, how to increase consumption of meals, and just different things that you would need to do to be able to start your own program and secure funding from different grants and such, so that you can have universal school meals at your school. We also talked about partnering with other groups to raise awareness for this issue. And there is a group, School Meals for All, which I actually participate with. And we, in this particular group, they have, what do you call it? Like coalition meetings each month. And they have presenters at those meetings that talk about the impact of not having access to school meals. And they also support sending students to visit the legislator, which there's a lot of things that this group does, and some of it is in a part of the legislation part too. So meeting with legislators to present the case for universal school meals, and then also having student ambassadors where the students kind of take ownership of this issue as a way to also teach them about advocacy and also to help their fellow students. Next slide, please. So we conclude that food is medicine. I'm pretty sure that we all know how important nutrition is. And of course, if the students don't eat, then it makes it more difficult for them to learn and focus and concentrate. And so that's why we're really passionate about this topic. Next slide, please. And the last thing that I want to talk about are the team dynamics and the project progression. That was one of the things that was suggested to us. So some of the struggles and lessons learned that we had, the first one was scheduling. It was difficult to kind of get everybody on the same schedule. And so what we learned from that was to establish key point people for tasks. And then, they, have that assigned out. And then you would go back and submit it to a Google document. And that seemed to work really well. One of our group members, Ben, he was really good at creating a what is it called? Like I guess kind of like a task management thing. He had some website. I wish I knew what it was, but he was able to create and assign tasks for everybody. And so that was easier when we weren't able to meet as often. The next struggle that we had was team members were in various stages of education. So I'm a recent graduate. Michael is in his 4th year, and Ben has started residency. And so that was a bit of a challenge with us being in different stages because we all have different focuses and just different things going on, because Michael is doing rotations, and you never know when you're going to finish when you're in the hospital with the rotations. And then when you start a residency, you're just absolutely slammed. So the lessons learned in that regard was to remain flexible when outcomes were not readily available, because sometimes that could get a little bit frustrating. But we, again, remain flexible and, of course, understanding to everybody's different places in their education. And then the last challenge was coordination with stakeholders. And I don't know, I personally would say, I don't know if my team members would agree, but I would personally say that we needed to communicate early and often when we were facing unforeseen challenges, because what I think that so many of us try to do is like, oh, we've got it, I've got it, because in this profession, that's kind of what's kind of expected, that you suck it up, that you do it, you've got it, you don't complain, and everything's under control, everything is fine until it's not. And so it's really important to communicate early and often when you're facing certain challenges. So that was something that we definitely talked about and learned later on. Next slide. And that is all. Thank you very much. Any questions?
Kira, thank you so much. This was a phenomenal presentation. And this last kind of summary that you've provided in reflection is so important. We're going to move to the next group, and that's not because the questions are not important for this. In fact, they are. We're going to come back to it. And your kind of honest assessment of how the group kind of navigated this is something I suspect many groups have navigated. And so let's put a pin in that discussion. And those that are listening, I want you to be thinking about that as well as we go through. Would like your reflections on that. But great presentation, tremendous topic, and really important reflections. We'll move to the next group and then we'll come back to that and can kind of open it up. But move to this next group on the road less traveled, and we're going to travel it sounds like.
Yeah, we will. So our group talked about transportation. It's kind of been a topic of discussion in every presentation today in some way or form, is transportation and getting access to care. So we really took this with a wide lens to look at transportation barriers in North Carolina and really like nationally. And then kind of found a few broad solutions that can kind of point us in the right direction. So go ahead to the next slide. So our problem statement is just that patients' access to healthcare is not only limited by the availability of a provider, but the ability to travel to the care itself. Now, most of the time when people talk about transportation to care, they think of specialists that may be 30, 40 minutes away, but that's not necessarily the case. It can even be a provider that's 10, 15 minutes down the road and a patient's unable to get there because they don't have access to a vehicle, any sort of transportations, Ubers, Lyfts, buses, anything. They don't have access to that because they're in a relatively rural area and those availabilities aren't the same in those spots. So we really wanted to look at it and see how we could tackle it. So let's talk a little bit about the background first. Next slide. In North Carolina, 80% of the counties within the state actually carry a rural distinction in one way or the other. Now, there's some counties that have a lot of urban areas, but then as you go broader into the county, it becomes a rural spot. And some people will look at those counties and they would focus on things like transportation resources less, because like I said, people think 30, 40 minutes, okay, that's a travel time, 5 to 10 is not. But if I don't have a vehicle, 5 to 10 is still pretty impactful in my day. So it's really important to think about that 80% of our state is under a rural distinction that could be missing many of these factors. Next slide. One thing with transportation that was discussed a lot in a lot of the research we did was COVID-19, because it kind of put a microscope on every sort of social determinant of health in the country, but also put a microscope on transportation. So what it mainly did was highlighted existing transportation barriers. If any of you have taken public transportation, you know it can be an absolute pain. If things aren't on time, the train is late, the plane is late, the bus is traveling behind, there's an accident causing traffic, a lot of things can cause barriers. So COVID actually decreased the amount of availability because employees were decreased because people were using transportation less and routes were decreased. And a lot of times since COVID, those routes haven't been picked back up in the ways that they were expecting. So it's still a continued barrier today. The next thing that we all know, and probably some of us love, is the proliferation of telehealth. Being able to have a healthcare interaction over something like Zoom or some sort of online availability, that is kind of the forefront. And as we're doing today, having a Zoom encounter, it kind of highlights the importance of having a telehealth option for people that can't leave the home. However, this is also limited by access to internet or even access to any sort of personal connection like a computer or a phone. That's another barrier for another day. And the last thing is COVID did create a few new barriers, and having that exposure to passengers, a lot of people know if you've taken public transportation, like I said, you're crammed in a tiny space to get as far as you can go. COVID limited that availability, requiring more space, more access, and now it's creating new problems for down the road. Next slide.
Good stuff, Sophie. I'm going to take over from here for the next few slides. So going into a little bit of the findings that we discovered while researching this project was one of the additional barriers that a lot of the patients and their families will also face is parking prices at the major hospital systems in North Carolina. These can lead to additional burdens financially on both the patient and the family members at already what seems to be a sensitive time. Obviously, if something is going on to where they need to be in the hospital, they're racking up other medical bills. And when you find that parking over time, maybe for a day or two, is not such a big deal, but when you have extensive lengths of stay up to a week, months at a time, even up to a year in some cases, these parking prices can really, again, add that extra burden onto the family members. So we can see that, at Duke University, this is one of the higher of the paid parking systems in North Carolina, of up to $12 a day or $2 an hour, and get as low as zero at ECU Vidant hospitals, but usually minimally around the $3 range. So we can go ahead and go on to the next slide from here. In addition to that, we're talking about public transportation, especially in rural areas. We don't have the options for the bus systems, the railway systems, that sort of thing. So people have to rely on their own form of transportation to get to and from their healthcare. So with that being said, we're looking at the cost of used vehicles in North Carolina, especially over the last few years, how they've tend to be increasing the same way everything else has increased in price over, these last several years. But when it comes to transportation in particular, you can look at a used vehicle anywhere from upwards of $30,000, which again, that's something we've all found to be a frustration over the last, handful of years, just the rising cost of everything. And then in addition to that, when you consider the add-on cost of having a vehicle in general, such as getting your title, your registration, your inspection, license plate fees, yearly inspections, that sort of thing, that can just add on to this cost, which can create those additional barriers for patients to get to and from, and not even just, having a regular vehicle to get to and from, but you have to consider patients that have to utilize wheelchairs, but whether they be manual, electronic, so on and so forth, and they'll need even more specialized vehicles, which can cost, significantly more than your average vehicle. And then lastly, the cost of gasoline has steadily risen over the last several years. The averages weren't in for 2024 as of yet, but last year, across the range in North Carolina, the average price of gas was $3.52 per gallon, and that can also influence people's decisions to go, especially long distances from rural areas into areas where they can access their healthcare. Next slide, please. So some example initiatives that we've already had in North Carolina have been some rideshare services, such as through UNC. Even these are kind of exclusive in some sense, whereas for the UNC rideshare service, they're only available for the members of the Medicare Next Generation. And it does have a cost to it, a yearly cost of about $500, which that can reduce incentive for patients to participate, whether or not they have their own vehicle or not. They could utilize this service if they can also manage that yearly cost. So it is one option. There have been some systems such as Atrium Health that provide like a hospital at home program where they're doing inpatient levels of care at home. They can focus on comprehensive care. And they can also, especially with the COVID pandemic, they found that was also limiting or addressing the limitation of the brick and mortar facilities because so many beds were filled in care or in the hospitals in acute care that this was another great option to get, again, care to people outside of the hospital system. Through Duke School of Nursing, they have also implemented a few programs where they travel out to patients' homes, focusing on HIV prevention. They do the COVID test. They can provide COVID treatment. They've also done just general education for older adults in the older community to maintain their general health. And then here in Johnson County, we have the JCATS, JOCO rideshare service. We often see their vans driving around, at least in my area, all the time. And they'll do scheduled pickup and drop offs at $6 each way. They don't need the insurance to get it or anything like that. They can just pay that essentially a $6 fee and get to where they need to go. But it is scheduled, so that kind of makes it a little bit better than just having it picked up at random times throughout the day. So that is a good option for our area here. And I believe we can go on to the next slide. And I believe,
Yep.
yeah,
All right. So I think for the next couple of minutes, I want to focus on some of the solutions that we considered predominantly based on existing infrastructure, right? So we don't want to kind of propose a system that will be unsustainable financially. So we tried to kind of see what's out there and how we can build on it further. So I think like mobile care initiatives are one way to bring care directly to the patient for someone who doesn't have a car, for someone who doesn't have a public transportation system near them. This can bring the care directly to them. So this can be led by clinicians at all levels. It does not have to just be physicians. Physician assistants and nursing especially can lead these home care and mobile health integrated programs, and they can significantly bridge the gap. And it can be a way to bring care to patients who really need it but don't have a way to get to it. Next slide, please. I think virtual care is loved by some, not so much by other, but I think it provides an opportunity to increase access for patients who don't have ability to get to their screening, get to their primary care visits. I think for some things that don't require urgent in-person attention, virtual care can provide another method for patients to get the care that they need. Now, with the caveat that it comes with their own barriers. For example, older patients who need access to care may not be able to navigate the technology required to be able to set up a telehealth system in place. So I think this comes with some limitations on it as well. Next slide. Are we missing a slide?
Yeah, I think we skipped a slide. If we go back a few. One more. Yeah.
Okay, perfect. And the other thing that we wanted to talk about was Everett briefly mentioned the rideshare services that are available and some of the programs that are in place. We think that increasing availability of these large rideshare services for all patients without significant limitations can significantly improve the ability to get patients to where they need to go. Ubers are everywhere, Ubers and Lyfts are everywhere. So if we can tap into that system to create opportunities for patients to get to their visits, that can profoundly impact their health as well. Hospital systems themselves can offer to create rideshare systems through volunteer programs. I know one of the programs exists within UNC as well, and I know about it, but a lot of patients do not know about it. So I think this again comes with the asterisk of creating more awareness of the resources that are already in place before we take initiatives for multi-million-dollar new projects. And also, I think a greater public transportation infrastructure will do us all good, especially for patients who cannot drive, who do not have a license, who are unable to operate large vehicles. So these are some of the programs that we looked at. Some of these are already in place, but I think increasing the availability and volume of them can significantly impact patient health. Back to the second to last slide.
Yeah, that one. I was gonna take this one. One thing that I think as future clinicians is really pertinent to us right now is ways to increase providers in rural areas. I'm sure I'm not the only one that's heard it or been recruited to kind of consider working in rural areas. And I think it's an important topic, not just for us as students, but to take back to our institutions to discuss ways to do this in a healthier and more sustainable manner. So I have this recruit, uplift, incentivize, and sustain pattern that I think a lot of it can come from what we've learned about for the last year is ways that we can uplift each other, ways we can call on our strengths and ways that we can move forward as a team and work in an integrated manner. And the same way can be done to increase providers in these rural areas. First off, recruitment, being able to recruit providers, no matter the specialty, whether from medicine to physical therapy to PAs to nursing. If we recruit providers from the areas, that will incentivize them already to go back to those areas. But a lot of that also comes with uplifting the individuals once they get into medical school, that heading towards a primary care route or heading towards a rural area sometimes can be stigmatized in education, and that shouldn't be the case. And being able to uplift them in their journey and be like, I understand this is your purpose, this is your passion project, you 100% should do this. And then incentivize, I think, is important too. Being able to take the public loan forgiveness options and use that and continue to grow that pattern and help these communities by having providers in the area, even if they're being incentivized to do it, is already going to improve their healthcare outcomes. And lastly, we have to sustain these programs. You can have providers incentivized to be in these programs and they have to work for 3 or 4 years in a rural area, but then oftentimes leave. Being able to put them in these rural areas and sustain them. One thing NCMS is doing and has worked really hard about doing in advocacy is talking about Medicare repayment plans for physicians and being able to uplift and sustain practices in rural areas so that they can provide the care they need without worried about financial burden and things like that. So that's another piece of sustainability that can come all around and how we can increase providers in rural areas, but really incentivize and uplift them. Next slide. And this is the team. And we'll be happy to take any questions.
Presentation. Kudos. Questions for this group? Comments?
I think comments, great presentation. I could talk about telehealth all day, but we should think about phone visits, you know. People don't like I think it's easy to do, but I think phone visits are very useful. I call my patients all the time and I think and have something like that. The other thing, I think the Uber is in other programs seen it, the Uber is a huge potential, because I don't think we'll get new bus routes out. The last thing just to think about this, just a comment, since I'm older and reflecting back on being in medicine a lot of years, the actual visit, it might be seen as a hassle, but it's also a social visit. For example, Johnny came in last week with his wife and I said, "You're stable. Why don't you don't have to travel across the state?" He said, "No, don't cancel the visit because we celebrate by going to the mall afterwards. So if you don't give us the excuse to get out and about, and it's like a social visit." And so there is a social connection to these visits to keep them going. But great work.
To kind of piggyback off the telehealth thing, especially, I mean, we found how important that was during COVID. I was still a PT tech at the time when COVID was happening, but I was really pleased last month at the APTA. They released a report through the Peterson Health Technology Institute that recognized that if led by a physical therapist, because I mean, we're obviously so hands-on. It's a hot topic in my field at the moment. That clinically meaningful improvements were possible if led by a PT through telehealth. So that was always really exciting to hear. So you kind of get that same what you're saying, that social visit, even if we were to come back, hopefully never again to that sort of COVID environment where people can't come into clinic with us. It's very social. You get to have that conversation and still maintain some benefit, whether it's be just for a checkup visit, mental health visit, and apparently for PT as well. So just a little plug there, but very excited to hear that too.
No, I think that's huge. I saw something about physical therapy over virtual could work. I'm glad you said that and echoed it. That's going to be a huge advance unless contested, because they're worried about, doctor visits is all.
Yeah, I mean,
That's great.
yeah, definitely some limitations there. But hopefully, they'll keep progressing the technology so we can continue more benefit from it.
Well, this is great discussion and just a ton of phenomenal topics that you all have covered. Um, Thank you all for these great presentations. I think I have learned a lot. I can see in the chat and in our discussion, how much we all have learned as we've kind of dove into these topics. We have one last reflection, and so we're going to give Brenda, if Brenda's available, a couple of minutes to reflect. And Brenda's like one of our most courageous FCLC members this year. And she's been in a difficult spot with the team where there was just a lot of challenges with her team. And so she wanted to share, I think, or was willing to share just her journey over this past year with her team and kind of where she is. And I'm completely putting her on the spot. So I know we can sort of come together as a team kind of around Brenda. We'd love to hear your reflections, Brenda, of kind of what your team went through, what you learned. And Shakir, this is going to kind of come back to some of what you introduced to us of just part of this is a journey to tackle a healthcare issue, but more importantly, it's a journey to learn who you are as a leader and how you lead as a team. Brenda, we'd love to hear your reflections of just kind of what you went through with your group, if you wouldn't mind sharing. And we can see you, but we can't hear you yet.
Can you guys hear me now?
Now we got you.
Okay, awesome. Sorry. So thank you so much for having me today. It was such a joy to hear everybody's presentations and just listen to the different diversity and the different issues that, we've tackled and we've seen. So I applaud you guys for everything. Unfortunately, I won't be presenting my project, but this comes with, a heavy heart, but also an evaluation of what this program has been to me. Our group, kind of reflecting on it, didn't surpass that, I think what we were talking about earlier is we came together as a group, we talked about our issues, we individually worked, and as I reflect on it, it's kind of like we got together as a group, but we didn't completely come together and form that unity that we should have had, We worked individually, we brought up different topics, different points. But at the end, we couldn't complete the assignment. And we've talked about, having different things happening in our lives. A lot of us were in the last year of med school, getting their residencies, and unfortunately, we did not get to complete that. And I think I earlier had said the word wasn't anger. I think it was disappointed in myself for not being able to complete the assignment. But I don't think it was anger. I think it was just disappointment for that lack of, what I could have done or what we should have done. And I think now that I reflect more upon it, I was like, man, we didn't do it. I could have done this. I should have done this. I should have done this. And I think my mom, she gave me really good advice. She says, it's not what you could have or should have, it's what you will and what you can do now. Reflecting upon this situation that happened now, going into, residencies and going into, practice as a pharmacist, whenever you have these collaborative practices, what can you do to make sure that, once you're in your job that, these things don't happen? Because right now as a student, it's kind of like, oh man, like it didn't happen. But, once you're practicing, once you're going through these collaborative practices with other people and trying to find the main ground and build a project, it's really important that we complete it. So I think now that I've reflected upon it, it's a learning opportunity for me that enhances my skills to be able to communicate more and just learn from those things that happen in order to make a stronger team in the future and to be, even a better leader if I could be.
Brenda, thank you. That was tremendous. I mean, Manisha's got hearts going up. I think we all have a little bit, you kind of touched our heart a little bit with just your honest reflection. And like, kudos to you, kudos to all of you for really digging into this year. And the assignment is not to solve a social determinant problem. Like they still exist. They're going to exist for a long time. It is to learn how you as a person, as a healthcare provider, can come together with others and build a team. And you have just reflected on something so important that, the task is important, but it's the team that you build as you're doing that that really moves things. And we heard that in a number of these presentations, right? It's the people you put together for CAFOs. It's the relationships you build with that legislator individual. It's the team that you build as you're working on these that is so influential and really what's changing things. So thank you for offering your reflection. We're going to open up. We're a little bit tighter on time than we had wanted, but any other reflections from anyone in the group as you kind of hear from Brenda? Anything you all went through, any kind of reflections you all have on some of the ups and downs of working with the team, as a team, stuff like that? Anything anyone wants to share?
I do want to share something, and I put this in my evaluation about the program itself. One thing I do appreciate now, a lot of the trends, like for me, other people, they probably saw transition was happening, but that was never communicated to us until tonight that things have occurred. And I'm like, a lot of times it seemed like venting sessions at times. I feel like my first session, I was like, okay, this is Asia Lorraine. Like, this is how I communicate. This is how I need people to communicate with me. I'm a red, that's 3%. Some things, I'm not necessarily a type A person. I'm like progression, not perfection. Because if you're perfection, you think you can't do more, but you can always do more as you learn more. But I think a lot of times, I think we also have to take ownership ourselves, because you kind of know what you have going on in life. Like unless it's like a health condition or something, or you can't really predict that, but you already know if you're a third year or fourth year, some of that stuff that's kind of situated. But I guess some of the things that I guess when we signed up for the program, I didn't know we had to do a paper, didn't know we had to do a PowerPoint. So these are things we didn't know until after we got on. And so one thing about our group, I kind of had rapport with Maddie, and I had rapport with Maddie, and I knew Jordan, I met her in passing. So we kind of like, okay, this is gonna be our group, gonna be a solid group. Because we kind of know if stuff gets dropped, we kind of have that feel versus trying to add on another person or another individual we really don't know. And that's another another, like, I guess, like stressor at times. But I just think some things with the program, I think it had a really good intention, but I think if we had more like check-ins, or just communicating with even the mentors, instead of we just being there, sometimes you're there, sometimes you're not, it's not a lot of cohesion. So we can't have cohesion within the cohort if it's not cohesion from the top with us.
Tremendous feedback. Thank you, Asia LeRae, for that. I see Manisha, Laura's head kind of nodding. That's extremely important. Thank you
And I was gonna say,
for
Erica did a
saying.
really good job. I just want to always like shout her out. She made sure we had all our stuff and sent out. So I just want to give her props. And I don't give everybody their props, but I just want to say that was one of the things that just kind of was echoed around. And it's just, I want y'all to be great. Because these
Good.
are also
Erica
jobs.
is great, Asia LeRae. We love that. We all love Erica. She gets two huge props. I think that's well stated. Any other reflections on the team group as you all went through, things you learned, things you're taking away that would be helpful to share?
Roy,
Correct.
I just like to echo, what Brenda was talking about. I was involved at an Academy of Neurology. We had people putting these groups together, and they did tremendous efforts, but lots of them didn't come to fruition per se. And what you learn from failed opportunities, because this is the things for scientific journals. We all see the positive results or the results that work, but we don't see the negative stuff. And this is real life. So there's no such thing as failures. There's learning opportunities and being diversified. You have to be flexible. So to me, not all about me in an academic, I'm kind of in small parts in different places to learn about different things and be open-minded. I wouldn't have thought about social determinants of health. I thought it crossed all the boxes, and now I realize at the end of the day, it's important. So, Brenda, I think, it really is said, there's no such thing as failures. They're learning opportunities. And if you asked me to speak, I'd be on telling about 20 times more of things, which, Roy, you just learn and reflect. And it makes you, I think by failing, you really can learn. But I think you
Great
guys did great
point.
jobs, and even if you attempt them.
Great point. Well said. Laura, what are you thinking? You want to close us out a little bit here? You always have good thoughts.
Sure, sure. Well, first of all, congratulations to this class. You guys did an amazing job, and we're super ecstatic that you guys that worked so diligently with each other, or at least you attempted to come up with a topic that you guys were really passionate about, to discover what the problems were, and to come up with solutions. I also love the fact that you guys were just super reflective throughout the entire process. And I think that is something that is so important for us to take, especially as you guys are moving from transitioning from students into clinicians, but always still being clinician leaders. The importance of reflecting on what you have experienced, what you have gone through, and you have reflection. What improve? What do I need to do to improve the situation? What can I possibly do to improve this group dynamic? And I think as long as you guys keep that piece of making sure that you reflect, that's going to be super important as you move on into your careers. And the last thing I want to mention is something that you guys probably already know this, but that your voice is super powerful and is a powerful tool for advocating for your communities and the patients that you serve. So I want to encourage you to continue to use your voice, continue to use that power, continue to do good. We are proud of you. We are excited for what's next for you, and please keep us posted. And then lastly, to all the folks that we invited, thank you all so much for your attention, and also for your insightful questions. This graduation presentation would have been the same without you guys.
And nobody can say it better than that. So I'm pretty sure every Olympian just listens to Laura right before they're about to go out there and like make it happen, because that was inspirational. This whole evening has been extremely inspirational. Thank you all for your dedication and work. Erica deserves huge kudos. Asia LeRae started it. We all got to jump on that bandwagon. Huge thanks to you, Erica. Thank you all for joining us for this entire year and tonight. Please, we are going to follow up with a QR code to an evaluation. We just didn't quite have time to give you time tonight, and we want to be respectful of your time this evening. I would implore you to please give us feedback so that we can improve as we move forward. Good things, bad things, as Cormac said, we're going to learn from all of those and really appreciate your honest and candid input about how we can improve the program as we move forward. Erica, final word, maybe.
Oh goodness, I was typing it in the chat because I was kind of having a bittersweet moment over here. I will say I am extremely proud of each of you. I know we've had some challenges this year, but challenges only make us stronger. They grow us. And obviously you all are here in this program because you wanted to grow, but you've also grown to show us some things that we can do to be better as well. So I appreciate each and every one of you for that. We want to stay connected. And I'm not saying this just from an NCMS perspective. We want to make sure that if you have successes, share them with us. We want to be your cheerleaders, not just because you're an FCLC, but because you are our FCLC Now Kipple family. So please, please, please keep in contact with all of us. And I wish you nothing but Godspeed. And your evals, if you can. Don't forget to send me your confirmation links. I'm still on you, so I've sent the email to each of you. If you can send me your confirmation screenshot, I would greatly appreciate it. And thanks for those who have already done it. So have a great evening.
Thanks, everyone. Bye-bye.
Bye.
Have a good night.
Good night.